Hello, and thank you for tuning into the program again. I'm your host, Neal Howard, here on Health Professional Radio. In our series on the North American Menopause Society's annual meeting being held in Philadelphia this month, we have a guest with us today, Dr. Michael McClung. He's the founding director of the Oregon Osteoporosis Center, and he's joining us here on the program to discuss his presentation at the NAMS. And he's going to talk about long-term treatment of osteoporosis. Welcome to the program, Dr. McClung.
Yes, thank you.
Glad that you could take the time. Now, give our listeners a bit of background about yourself and talk about your presentation at NAMS.
Sure. I am an endocrinologist and have been involved in caring for patients with osteoporosis now for 40 years and have been involved in the evolution of the entire set of medicines that we now have that can effectively protect patients with osteoporosis from the risks of spine and hip fracture. We know that osteoporosis is a chronic problem. Bone loss happens gradually with aging in both men and women, and particularly at menopause in women, and that results in an impaired strength of the skeleton and predisposes those patients to fractures of the hip or spine. And we now have a menu of treatment options that is effective in improving the strength of the bone and reducing fracture risk, but we don't yet have a cure for osteoporosis. And as a result, we need to develop a long-term treatment plan, particularly for women who began therapy in their 60s and in whom we have many years of treatment to look forward to. And my presentation reviewed those ideas here at NAMS.
Does the treatment differ greatly among men and between men and women when it comes to osteoporosis?
No. The pathogenesis or the reason for age-related bone loss is very similar between men and women, except that men don't have the temporary interval of rapid bone loss that accompanies menopause and estrogen deficiency.
So you mentioned, being 60 years old and having many years of treatment to look forward to. Are some of these treatments more agreeable to the long-term use than others? And do you start off with something short-term and then go long-term?
Yes. The key element is that treatment decisions have to be individualized. And there are 4 categories of drugs that we choose from when beginning therapy. And of course, the drugs are on top of the general measures of adequate nutrition, adequate exercise, and avoiding lifestyle factors that can be harmful. But if drug therapy is indicated, we have 4 choices. And depending upon the age of the patient, and especially depending upon the risk of fracture at the time treatment is started, we would choose among the different treatment options. However, only 2 of the 4 categories of medicines are considered for long-term treatment. The most commonly used category are called bisphosphonates. That's the drugs that most patients are treated with. And then the other drug is a drug called denosumab, a monoclonal antibody that has been available for treatment for the last 7 years or so. So depending upon the severity of the osteoporosis, the age of the patient, and other clinical risk factors, we make decisions and choose among those treatment options.
Are people aware of these options and how they differ, between long-term and short-term care options? I mean, among physicians, I'm sure that there's awareness. But when it comes to your patients, how aware are they of some of their options, especially with one you spoke of being just 7 years old?
Right. I think that when people think about osteoporosis therapy, they almost always think of the bisphosphonates. Those are the drugs that have been around since the mid-90s, and it's the drugs that we have the most experience with, but also are the drugs where the rare side effects have been reported that have captured undue interest or had generated substantial concern. So the bisphosphonates have been associated with osteonecrosis of the jaw, a delay in the healing after tooth extraction, for example, or have been associated with very rare, unusual fractures of the thigh bone after many years of therapy. That's what people think about. And the pharmacology of those drugs is unique. These drugs stick to the skeleton, and when treatment is stopped, there's a very slow offset over 2 or 3 years of the effect. And so the concept of having a holiday from bisphosphonate therapy for patients who are not at high risk after 3 to 5 years has been developed. And that's a very reasonable approach for some patients on bisphosphonate therapy. Denosumab works totally differently. It's an antibody that circulates in the blood, does not stick to the skeleton, and like most medicines, when treatment is stopped, the benefit and the treatment effect goes away very quickly. So there should never be a holiday from denosumab. There may be a time to switch to a different medicine, but and physicians and patients are often confused about the concept of a holiday and have extrapolated or taken what we know about bisphosphonate holidays and attempted to apply it to other medicines, and that is not appropriate, we feel.
With the some of the side effects that you mentioned and some of the challenges associated with osteoporosis and the medications, do you find any compliance issues with osteoporosis, as some physicians find with many other drugs and the conditions that those drugs are used for?
Yes, poor compliance or poor persistence on therapy is well documented with particularly the oral drugs for osteoporosis, similar to drugs for lipid disorders and diabetes and high blood pressure. Beyond that, though, the concern about these very rare side effects generally associated with long-term therapy for more than 5 or 10 years, has prohibited or inhibited patients from making a decision about even starting therapy. So in the past 10 years, the proportion of patients with osteoporosis in the United States who receive treatment has decreased by 40 to 50% because of these concerns of rare safety events.
Have you noticed any changes in guidelines about osteoporosis treatment and therapies based on some of the findings after these drugs have been in use for a while?
Yes. So the first guidelines for osteoporosis in the United States were provided in 1998, and several professional societies have had guidelines and have been updated on several occasions. Our Clinical Endocrine Society provided the most recent update just last year and incorporated much of what we've learned about which patients would be candidates for a bisphosphonate holiday. The guidelines make the very strong point that holidays should not be considered for denosumab, and also make the point that after several years of bisphosphonate therapy, switching to a different drug has the potential to provide additional benefit while avoiding potentially the concern about the long-term side effects of bisphosphonate therapy. So as we learn new information with the long-term experience with drugs, the guidelines attempt to keep up and provide the best guidance based upon what we know.
Now, where can we go and get some more information about the Oregon Osteoporosis Center and about some of these groundbreaking new developments in treatment as well?
Well, I'm probably the person to get information about the Oregon Osteoporosis Center from. We're located in Portland and have been involved in clinical research and clinical management for a long time. The National Osteoporosis Foundation, the American Association of Clinical Endocrinology, and the North American Menopause Society all have treatment guidelines and information on their websites that provide information both for clinicians and for patients about osteoporosis, about risk factors, about treatment options, and about guidelines for how those treatment options should be applied.
Well, thanks for coming in today, Doctor. It's been a pleasure.
Thank you very much. Bye-bye.
You've been listening to Health Professional Radio. I'm your host, Neal Howard. Transcripts and audio of the program are available at healthprofessionalradio.com.au and also at hpr.fm.